Now, when you talk about corneal edema post-cataract surgery, is basically an undesirable complication. Nobody wants to have a patient looking like this on day one post-operative. So there are preoperative risk factors. The most common is if there is already a pre-existing compromised endothelial function, the common of which is Fuchs endothelial dystrophy or posterior polymorphous corneal dystrophy. You can have the same with ICE syndrome, glaucoma, long-standing uveitis, or any prior corneal trauma. If you fail to recognize these kind of changes pre-cataract, then you're more likely to face with the post-operative corneal edema. So it's important always to dilate the pupil and on retroillumination, look at the reflex from the cornea. You might be able to pick up the gutted changes. The other preoperative risk factors, which are related to the hardness of the cataract, the depth of the anterior chamber, and how much your pupil dilates. We know that if you have a harder cataract, or if you have a shallow anterior chamber, or if you have a non-dilating pupil, you're likely to have a more prolonged and traumatic surgery, which can be detrimental to the corneal endothelial cells. Intraoperative factors which may result in postoperative corneal edema include Descemet's membrane detachment, trauma related to instruments, excessive use of phacoenergy, toxic effect of the irrigating solution, and if you have any vitreous loss or you place an IOL in the anterior chamber, so related to that also you can have increased endothelial cell loss. Post-operatively, again, you can have raised IOP if you have a persistent DM detachment or you have vitreous that is touching the endothelium, toxic anterior segment syndrome, endotheliitis. If you have hypertonic wound leak, that also can result in corneal edema and chronic inflammation, especially from retained nuclear fragments. Let's look at some of these causes. Striate keratopathy is maybe the most common, usually seen with hard cataract and prolonged surgery. This used to be quite common when we started off with learning phaco with the Universal One phaco machine, which did not have as good fluidics as what the modern day phaco machine has. So we used to see striate keratopathy and we used to assume that this is normal and this will resolve over a period of next few weeks. So here you have corneal edema. There is minimal inflammation. The IOP is normal. The edema is usually located centrally. And if you use frequent steroids and some hyperosmotics, this resolves over a period of time. DM detachments can be focal or total. Focal are usually close to your main incision or the side ports. Usually occurs if you have used blunt instruments, and sometimes if you hydrate and if your fluid has gone into the plane between the Descemet's and the stroma. Sometimes you can have DM detachment away from the main incision or side port due to direct trauma with the instruments. You have corneal edema, eye is usually quiet. You can use an anterior segment OCT for easy diagnosis. If you have planar detachments which are not separated greater than the corneal thickness, you can observe them, but do a serial anterior segment OCT to see whether they are progressively worsening. If you have progressive worsening, you can inject air or 20% SF6 to reattach the DM. But make sure that you keep the pupil dilated and avoid a pupillary block. That's just to show you the anterior segment OCT images of the DM detachment. Toxic anterior segment syndrome results in a diffuse corneal edema associated with a lot of pigment dispersion. The pupil can be mid-dilated and fixed. And there is inflammation, but it is usually restricted to the anterior segment, and it's often associated with raised IOP. Here, you have to differentiate from endophthalmitis, either infective or viral. The medical management is usually steroids to control the inflammation, use hyperosmotics and IOP lowering agents. But a majority of these cases usually don't recover and need endothelial keratoplasty. Infective endophthalmitis, again, can result in a diffuse or sectoral corneal edema. The pupil is irregular, often from the posterior synechiae, and the inflammation need not be restricted to the anterior segment. You can have inflammation in the vitreous cavity as well. And these are also associated with raised intraocular pressure. Early diagnosis is essential in these cases, and appropriate antimicrobial therapy needs to be started. And use of steroids depends on the infective etiology. The retained nuclear fragment is again something that results intraoperatively. If you have a small non-dilating pupil, you can get the lens fragments, which can get either trapped behind the iris or subincisional, and then you may miss it intraoperatively. usually results in an inferior corneal edema with some amount of persistent inflammation and a raised IOP. Early diagnosis is essential because the longer the retained fragment, the greater the endothelial damage. A gonioscopy or an anterior segment OCT is useful in diagnosing a retained nuclear fragment, plan early removal, treat medically with hyperosmotic and steroids and IOP lowering medication, and you can overcome this problem and patient may not require subsequent endothelial keratoplasty. So basically, in conclusion, these are the common conditions in which can result in corneal edema post-cataract surgery. It can be distressing both for the patient and the operating surgeon. Early diagnosis of etiology can help you plan the appropriate management. I think anterior segment OCT has a role both in the diagnosis, assessment of severity, and also to monitor the outcome of therapy that you provide. Endothelial keratoplasty procedures such as DSEK or DMEK can definitely help restore the corneal endothelial function and corneal clarity for cases which do not respond to the medical therapy. Thank you. Thank you for your patient hearing.